and I is here. Who am I? That's who I am. That's who this guy is. Right there, right there. Jonathan Staiano, consultant plastic surgeon. Well, used to be a surgeon. Used to do operations back in the days. Do you remember when they used to see people in person? Do you remember that? Well, back in the day, I used to do operations. I'm now a social media influencer, and so spend my time engaging with my people. So I'm just going to assume the audio is working. I'm just assuming that, I'm sure if it wasn't, the chat, look at that, the chat is kicking right off. Dawn, hi. Olivia, so hi, good to see you. Hay fever season is here, right? You are here, yay. You are here, yay. Okay, good one. Hey, hello, laughing. So I'm assuming you would tell me if it wasn't working. Jonathan Staiano, ex-plastic surgeon here. No, I'll tell you something. Actually, we are in the process of putting together protocols and what have you, ready for the reboot, and we are ready to go, and we are. Oh, look, Catherine's here. Catherine McLeod. Catherine McLeod is in the house. Who's Catherine McLeod? I know who Catherine McLeod is. Right, hi, Catherine. Nice to see you. I don't know if this is relevant for you, but you can pop in and you can. That's enough now, Catherine. You don't have to see any more. It's all like questions. It'll be boring for you. Good, loud and clear is working as it always is, because I'm a pro, right? I'm a pro and I know what I'm doing. It's plugged in. I know where it is. I hope you're staying safe. I'm not bored at all. I wish I was bored. I got a wooden motorbike thing for my birthday, like that you put together. It's impossible. It's very, very hard to put together, but I'm nowhere near. I'm just all in pieces back there. I want to sit down. I did actually read my book today. I said to I'm going to go and read my book. So I went and read my book for a bit of time, but I'm not having as much. I tell you, when this lockdown gets lifted, I'll be like, what, already? I've got stuff to do. I plan to, clear the office for a start. I mean, I can see, look at that shelf there. I mean, what's going on there? There's a seat. I mean, what is, that key. Oh my God, that's key. Oh my God. Keys my parents, they sold that house. We've got this is the software for the fax software. This is the RotaZip spiral saw CD. I mean, come on. What else? CD stomper. Oh God. I mean, it needs a sort out, doesn't it, really? I mean, this needs a sort out as well. Is this really necessary, this big one? Anyway, so I've got a lot still to do. There's still a lot to do. And that is on the list, definitely. What else I want to do is I want to get, I've seen fellow colleague influencers, we all get together, all the social media influencers, we're sort of like a bit of a team, and they've got a TV. I think they've got a TV, big TV behind them with like just like their logo on it or something. It's up there. I'm thinking, big TV behind me with like the logo or something. I've got ideas, but so I'm not bored. I've got a lot on. Look at that. We're straight in with a question. Hold on a minute. Is that the same as my first? No, I've got a different. Dawn, you asked a question that I've got from someone else. That's good. How many TikToks have you done? Are you famous yet, Gemma? I've done 2 TikToks, and no, I haven't ventured into the TikTok arena since last week, actually. So that just shows. But you're right. I've got to get on it. I've got to get making content. So look at that, Dawn. Dawn's not messing about, guys. Let's cut with the chit chat because Dawn's going to get straight into this. Could a diastasis hernia be fixed using a muscle graft? A muscle graft? What's a muscle graft? So I got a question about that. Well, I'll answer that question, then I'll do my one. Well, I don't know what a muscle graft is, Dawn. A muscle graft. I don't. Do you mean, what do you mean, muscle graft? So a diastasis hernia could be fixed. So just maybe perhaps I'll ignore the second part of the question. That's what I should. If I was a proper politician, I'd be just glossed over it. So a muscle, yes. Diastasis. So hold on a minute. Diastasis hernia. So basically, let's get this terminology. Let's get this clear. A person who needs a tummy tuck, it has usually had something that has stretched their tummy, and that something is usually either a child, as in been pregnant or multiple pregnancies, or being overweight, putting on weight and then losing weight. So that stretch, when you put on weight and lose weight or have a pregnancy, stretches everything, and the rectus muscles, the six-pack muscles, which are two muscles side by side, get stretched apart and don't really come back together properly and leave a weakness between those two muscles, which are normally at the front of your abdomen, your six-pack, like right at the front there. But if they've been stretched, they can be a bit stretched apart, and you can get a bulge between them. And that bulge is apparent if you lift your head and shoulders up off the bed, if you're lying flat on your back, or if you lift your legs up, straight leg raise, you can sometimes feel a bulge above your belly button. In that bit of abdomen, there's a bulge there, and that is known as diastasis of the recti muscles. So one is a rectus muscle and two is recti. So diastasis of the recti is that. Now, sometimes when you feel a bulge in the abdominal wall, you think it's a hernia. A hernia is, I don't know if you need to know this, I'm getting a bit technical, but anyway, a hernia is a defect in the abdominal wall. So instead of having a nice crisp abdominal wall, if you have a hole in that abdominal wall, which could be congenital, i.e. you could be born with it, usually inguinal down in your groin, or it could be acquired. You could have had surgery where they could have repaired they could have cut through the abdominal wall and then stitched it together, and then it could have come apart or whatever. But for whatever reason, there's basically a defect or a hole in the abdominal wall, and you have abdominal contents poking through that hole, causing a hernia. So a strict hernia is a defect in the abdominal wall causing a bulge. It looks the same from the outside because it looks like a bulge, but a diastasis is not, strictly speaking, a hernia. Don't know if you needed to know all that information. So a diastasis looks like a hernia, but it's not a hernia because the abdominal wall is actually intact. It's just weak, causing a bulge. Anyway, that's what diastasis is. So it's not uncommon for people having a tummy tuck, and it is an integral part of a tummy tuck, or of a full tummy tuck, not a mini, but of a full tummy tuck. Repairing that weakness is an integral part of the surgery, and what it involves is using some heavy sutures to bring those muscles together to repair the hernia. Not really repairing the hernia, but repair of the bulge, getting rid of the bulge, repairing the diastasis, or divarification is the other word. Get some fancy words in there. Divarification of the recti, or diastasis of the recti. It's the recti muscles are too far apart, and you bring them together. Part of oh God, I've got please comment and share down there. Sorry about that. Part of a integral part of a. Although please do comment and share. Where's it gone? There. Oh, there. All right, just don't forget, please comment and share. That's what we YouTubers do, okay? Although this is on Facebook, but still, still a video platform. So could a diastasis hernia be fixed? So could a diastasis of the recti? Yes, it could be fixed. Now, I don't know what you mean by a muscle graft. Again, strictly speaking, a graft is moving tissue from one place to another place. So you can do a skin graft, you can do a corneal graft, you can do a fat graft. You tend not to do muscle grafts. I'm trying to think what you do a muscle graft. You might do a muscle flap. Well, anyway, where you take a bit of muscle with its blood supply and move it to somewhere else, but that's hardcore surgery, and I don't think it is a thing, personally. So I don't know what you mean by muscle graft. Would I? But I'm just looking at my question. You can sometimes, if there is a big defect in the abdominal wall, you can use you would usually use a prosthetic, like a something off the shelf, something out of a packet to shore up the repair, like a patch, which would often be either, well, it could be nylon, could be a synthetic, or it could be a natural, like a dermal piece of tissue. Anyway, you could use something to patch it up, but you normally don't, which I think might be what you're talking about, a muscle graft. People use these dermal templates, these things that you can put over to shore it up. They're quite expensive. And then for a straightforward diastasis of the recti, you probably wouldn't need that. If it was a proper hernia, you might need that. Whew, oh God, sorry, the chat has kicked off. Wait a minute, get that shelf cleared, sort it out. I think you may have saw anything else. If you're having, if you was having an abdominoplasty, considering you couldn't do it yourself, who would you recommend? What do you mean? If I was having a concern, why can't I do it myself? I can do it, Dawn. It's just I'm knocked down. You're talking about Lawn. Do you want me to recommend someone else? But I do recommend people go close to home. So wherever you live, where do you live, Dawn? I can tell you if you live somewhere far away from me, but if you live next to me, I can't recommend anyone better. No, there's lots of good people. I'll tell you what I'd recommend, Dawn. Look for BAPS, BAAPS. Look for FRC, which is a British Association of Aesthetic Plastic Surgeons. They've got a list of surgeons, and they're proper plastic surgeons there. There's quite a lot of people on the BAPS, in the BAPS, and you're probably all right. BAPRAS is the other one, BAPRAS. So and if you look for FRCS Plast after the name, those are basically take homes if you're looking for someone to do a tummy tuck. I'm still waiting for Carol Baskin. Yeah, that was on the Instagram, not on Instagram, that was on the TikTok, wasn't it? TikTok. Tic Tac. Look at that. What an amateur. I just call it Tic Tac. Oh dear. Oh man. Won't follow you back on Tic Tac neither. Talk. Oh, you're not going to follow me back. Oh God. You're getting into talk I don't know about. Taking a graft from your leg muscle as patches don't work. Dawn, this is new to me. I'm sorry. I'm out now. I'm going to declare myself out on this question. Taking a graft from your leg muscle to your abdomen. I'm out on that. Tess, we spoke last week. I changed my profile. I'm the one with 9 children. Yeah, but do I need muscle repair then? Does every tummy tuck have muscle repair? No, not every tummy tuck, Olivia. I would say a large number of them, but not every single one. But I wouldn't worry about it too much because it's just something we do as an integral part of it. No, I mean if you're female. So Dawn, I'm not familiar with taking a muscle from your leg and putting it as a patch on your abdomen. That is not a technique I'm familiar with. And to be honest, I would look into it, Dawn. And I think you've got to be a bit careful if you've got someone who's doing it and they're like, I'm the only one doing it. Did I speak about this? I spoke about this someone, was it? I can't remember. But I'm the only one doing it. I'm, the only one in the world, blah, blah. You've got to think, well, why doesn't anyone else do it if it's so good? And it might be that it's a bit of a dubious thing to do. To be honest with you, Dawn, it sounds a bit dubious. I've got to be honest. Next week, it could be the next big thing, and we'll all be doing it. And I will eat my hat or eat my words. But at the moment, I'm not entirely convinced that taking a bit of muscle from your leg and putting it in your abdomen to repair, because to be honest, muscle is not a good thing to repair the abdominal wall with. The problem is not the muscle. The muscle's fine. Is the thick fascia, we call it, over the top of the muscle. So taking a piece of fascia, doing a fascial graft, maybe, but it's the firm, non-forgiving white covering over muscles, which is called fascia, which is how you repair hernias. So it wouldn't be muscle, but. Not sure, Dawn. I'm gonna just thanks anyway. Well, that's a bit of a like, yeah. Sorry, Dawn. I'll let you down. Dear. I got a question. Oh God, I had it a minute ago. Here we go. I got a question on a similar vein, but this one I might be able to answer. I had a C-section 3 months ago and also have a small hernia above my belly button. Would this be addressed with a tummy tuck? So, so the answer to that is yes, as long as it's a small hernia. So it's not uncommon. Sometimes we find them incidentally. You find a little, and again, this is a proper hernia, a little defect in the abdominal wall, usually around the belly button, a periumbilical hernia, little defect in the abdominal wall, and they're very easy just to stitch up, just to close, and then do the repair of the divarification of the recti over the top of it. So that is not uncommon to repair a small hernia. Now, if you've got a big hernia, then you've got to think, am I going to be able to stitch it together? Because if you're not able to stitch together, that's when you get into using meshes and these other things that you sort of patch on top. But certainly a small hernia could be addressed at the time of a tummy tuck. And as I say, sometimes incidentally, we just find one, and it's not a problem for it to repair a small one. Absolutely not. DP Desai, how do you decide if a hernia can be repaired by stitching together or needs mesh? Size. It's size. So if it's literally small ones, then they can be repaired. And most of the ones, / all of the ones that I can think of that you encounter can be repaired directly. You would only use mesh for a proper hernia, for a person who's got a hernia, which you would be able to diagnose clinically preoperatively, because we always assess your rectus muscles in the abdominal wall before we do a tummy tuck. So if you've got a hernia, then that will be a different kettle of fish, and that would be something that you would hope that we would be able to sort of notice preoperatively. And if it's even a smaller hernia, you might be able to repair directly, but certainly anything of any size, then you would think about using a mesh. But that's a good question, Deepika. That is a good question. So yeah, it's size basically. Nikki's in the house. If I had a mesh repair in 2007 to an umbilical hernia, would that affect having a tummy tuck with a muscle repair? No. It's all hernia talk. It is. It's hernia talk today. That's all right. It's all right. No, it wouldn't. I mean, if you someone asked something about this, was it last week? If you had like a big mesh there, then it might restrict your ability to get a good repair of that divarification, because it might splint the tissues a bit, that they don't come together very easily if there's a big, because a mesh basically gets populated with scar tissue, so you'd have a big block of scar, which would be how your hernia would be repaired, and it might make us make it more difficult for us to give you a good repair of your divarification. So it could still be done without affect having a tummy tuck. So it could still be done. I mean, it might, as I say, it might make it a bit more difficult for us to bring those muscles together. So yeah, it might affect it a bit, but you know, hopefully not drastically. Nikki, don't worry, I'm happy with it. Hernia talk, yeah, I'm mad for it. Hernia talk's interesting. My mum has a bad umbilical hernia. She had mesh, I believe. Looked like she'd had a tummy tuck as it was so flat. Well, there you go. Excellent. Bring it on. Yeah, any hernia questions, get them on. Get them on, you guys. Let's have it. In the absence of hernia questions, just in between the hernia questions, here we go. Question here. Question says, what aftercare do you offer? Can you purchase 10-year cover in case implants need to be changed? This is so aftercare. Aftercare for me and the clinic is, I would say to you that we focus on looking after people and don't charge for follow-up appointments. Don't charge if you have to come back to clinic at any time. If you're worried about anything, if you want to come back before surgery, after surgery, we're very happy to see any patients. If you've got any issues, any problems, see you, no problem at all. That's one aspect of the aftercare. The other aspect of the aftercare is if you need surgery, which is arguably probably more important, because obviously that's the expensive thing. So if you're a patient and you've had surgery 10, days ago or 10 years ago, you can come back and we'll have a chat about things, and that's fine. If you need surgery, then that is where the aftercare comes in, which is probably more might be more what you're thinking. And in terms of surgery, it is usually linked with the hospital. So the hospital offers between 6 and 12 months, depending on the hospitals, of cover for revisions. So if it doesn't look right, basically, then it will be put right without you paying. And that is most problems come within 6 months, to be honest with you. After 6 or 12 months, if you do have a problem, you can come back and see me or us, and we'll have a look and see what needs to be done. If you need surgery, you have to pay. Now, in terms of implants, to be honest with you, most of the problems are going to come in the first 6 to 12 months, because it's going to be they're not sitting right, too high, too wide, too up, too down, or what have you. The problems you're going to get with implants are longer term, which is why you're asking probably about this 10-year thing. And that's probably something like capsular contracture. Now, the implants themselves do have a guarantee, and all the implants have different guarantees. So that's one reason to maybe think about different types of implants. So, for instance, I can use any implant pretty much as long as the hospital can get it. I'm not really tied to any manufacturer. If I am using implants, I use for silicone implants, I use Nagor implants, which are made in the UK. They have a lifetime warranty, which covers capsular contracture and rupture. But that just means they give you a new implant. So you've got to be a bit careful with the wording, because people say, oh, don't worry, I've got a lifetime guarantee. It's all going to be fine. If I've got any problems, it's all covered. Well, hold on a minute. It's not all covered. It's just the implants. They'll give you a new set of implants, but you still need to pay for the surgery. So if you have a capsular contracture, and that is usually 5 or 10 years post-op, you still have to pay for the surgery, and that can be very expensive. So that is something to think about. So what you're asking here is, can you purchase cover? Now, the other type of implants I use are polyurethane implants, which are made by a company called Polytech, who are a German company and are just distributed in the UK by a company called Q Medical. And Q Medical offer a guarantee with the implants in terms of a sort of insurance cover. So if you have a Polytech implant, that comes with a 2-year cover on top of the hospital one, which is 6 to 12 months. And that covers you for £1,500, I think it is, per implant. So the insurance company will cover you for £1,500 per implant if you have a problem within the first 2 years. So that extends it out to 2 years. And at the end of that 2 years, they will contact you to see if you want to extend it. So there is that policy if you're having a Polytech implant that is provided by Q Medical. They do have a 2-year cover, which can be extended. And I've got a feeling, I should have checked this, shouldn't I? I've got a feeling it might be up to 10 years. I don't know, actually. I want to have a disclaimer on that. I'm not sure how long it goes on for, but after the 2 years is covered with the implant. And then after the 2 years, you can extend it with the company, but they will charge you. I don't know what the charge is, but they will charge you. It's like an insurance policy. So that is an option. So obviously we're talking about implants there. Nikki's back in. Good to have you, Nikki. I had a gallbladder/gallstone removal, but decided to pull a corner unit across the living room 2 weeks post-op. Stupid, I know, hence hernia repair. Don't make the mistake I made. Listen, people, you're listening to that? Did you hear that, everyone? Nikki had a hernia repair and then she moved a corner unit 2 weeks post-op. Is that a good thing to do? No, that is not a good thing to do. All right, things are healing, things are knitting together. You want that hernia repair to scar. It takes a couple of months for that to scar. You put tension on it, boom, it can pull open, just like a wound pull open. But a hernia repair, by definition, is closed under tension because you've got a hernia, you've got a weakness in the abdominal wall, so you have to close it up and close it tight. And so this is a sobering lesson for us all there, I think, from Nikki. Thanks, Nikki, for that. We will avoid corner unit moving for at least 6 weeks after our hernia repair. Very good, very, very good. Here we go. Why don't we offer discounts? Please, can you offer a reduction? Please, can you offer a reduction in your surgery price? Nice question. Like it. Right. Well, we don't offer discounts, and there's 2 reasons for that. And one reason is very or relatively sort of straightforward, and that is that the BARPS, which I spoke about earlier, which are Professional Association, Plastic Surgery Association, does not allow it. We're not allowed to offer discounts as a fully trained plastic surgeon and a member of BARPS. So members of BARPS are not allowed to offer discounts. So that makes it easy. So we're not allowed to offer discounts. And the reason we're not allowed to offer discounts, so obviously there's a reason behind it, is because it is a medical procedure. So if it's right for you, it's right for you. If it's not right for you, it's not right for you. You shouldn't be making the decision based on money, and we shouldn't be coercing you or encouraging you to have a medical procedure by offering you a discount and say, look, if you buy now, you'll get a discount. That is not ethical in a medical sense. So that is quite simple. Now, the problem, I can safely say the problem with certainly plastic surgery or cosmetic surgery in the UK is there's a lot of people who aren't plastic surgeons doing it. They aren't members of BARPS. They are not bound by our professional association. So in the same way that if you have a problem or they act unethically, or if they act in a way that you feel is not appropriate, you can't go to BARPS. I mean, you could go to GMC. They should still be registered with GMC, but GMC is for sort of quite big issues. They might actually be a GMC might help with this, but they're not accountable to BARPS, because if you're not a member of BARPS, then they're not accountable. And so I'm aware that some places do these things where they'll say, book this month and you'll get a discount and things like that. But that is not BARPS members who will do that. And but there are people out there who are not bound by those limitations. Now, I have to say that even if BARPS didn't have that stipulation, I still wouldn't offer a discount, because it doesn't sit very well with me. I don't feel it is in keeping with the values of my practice, because I don't want to have someone who says, oh, discount for cash, what can you do? Do it for 5,000, I'll book today, and things like this. And then we say yes, and then someone else who is, just assumes that's the price, then pays, 6,000 or 5,500. Then that's not really fair. And when I say it's not fair, I know it happens in the world. People wheel a deal and get discounts on things, but anyway, I just don't think it sits very well with me, and I don't want someone to feel that you can do a deal. And to be honest, it makes it easier for all the staff. It makes it easier for everyone in the office, because it's just like, look, really sorry, we're not really a price. We're not really a price driven practice, and patients who come don't really come because they're looking for a bargain. I think if you're looking for a bargain, you won't come to us, and you may feel a bit aggrieved. Oh, they're not offering a discount, and I understand it. I like a discount. We all like a discount, don't we? I like a discount, but it's not really in keeping with the brand and the way we do business. So I don't know. It's just what it is. It's just what it is. It's like Apple. And sometimes it makes it easier, it makes it easier to buy an Apple thing, because you don't have to trawl and look for discounts and look for, offers, because there's never going to be a discount. You just got to, you might say, look, that's a crazy price, I'm not paying it. Well, fine. I'm going to get, discount on, I understand that, and people will do that. And that's, that's the nature of the beast if you don't do discounts. There are people out there who'll be aggrieved and want to feel that they've had a bargain and things. And as I say, I'm one of those people. I like, you think, oh, wow, that's good. TK Maxx, love it. Home Sense, can't get enough. I'm there. So I totally get it as a consumer. But in terms of the business, it doesn't sit right with the values of the business, nor does it sit right with the fact that we're members of BARPS and this is a medical procedure. So anyway, I hope that's okay. I don't know what's going on here. What's going on? Olivia's putting all sorts of emojis on. Nice one. Jackie's in the house. Hi, JJ, your opinion, please. When this pandemic is over, I shall be rescheduling my op. What would be a reasonable time for recovery from a lower face and neck lift to be free of bruising and swelling, as my son is getting married in February? Hold on a minute, Jackie. I got that. That's on my list of questions, Jackie. Ooh, what's happening here? Anyway, I'll answer it. I've got it. I've got a few other bits I think about facelift, but anyway, a lower facelift and neck lift. So that is well, I'll talk about facelift in a minute because there is a sort of spectrum in terms of facelift. But it sounds like you're having a sort of full facelift, which means the sort of scar that goes around the ear and in the back, and then that's where the sort of neck lift comes in, the scar at the back. So that'd be a full facelift. So that's quite a big operation. And one of the problems with Facebook facelifts is because it's on your face, it is quite visual, so you can't really hide it. So I think for the first couple of weeks, you're going to feel fragile, whatever. You're going to feel fragile. You're not going to feel like doing anything for the first 2 weeks, I would say. You will probably start to feel better after 2 weeks. I don't do facelifts, by the way, Jackie. So that's disclosure there. So I won't be a surgeon anyway. But so this is just my, my view. But you better. Surgeon's always the best one to talk to about this. But anyway. First couple of weeks you won't feel doing anything. The problem is it'll look strange, it'll look quite bruised, it'll look quite tight, your scar might be a little bit obvious, and so that might limit you going out and certainly limit you in terms of the wedding or what have you. I would say after a month to 6 weeks you'll start to feel things will feel a bit better, a bit less swollen, a bit less tense, and start to feel a bit better. You might be able to cover things up with makeup and what have you and be presentable, but you'll probably still feel a bit uncomfortable. I would say if you can, 2 months. It's cutting a bit, isn't it? I'm getting married February, so that's around sort of Christmas time. I would say 2 months would be reasonable, Jackie, on that one. So I think 2 months would be where I'd be pitching it. But having said that, you could get problems. Something could not heal up properly. You might get a stitch here or there, or you could sail through and 6 weeks look good as gold. It's really hard to say. But because the other thing is you could postpone it afterwards. Are we doing Christmas? Are we doing surgery around Christmas? I don't know. Probably. But yeah, a couple of months is where I'd be pitching that one, Jackie. Julia's in the house. I think the deal thing, apart from money, which is a huge factor, when you investigate procedures, the ones abroad do packages which are appealing, but obviously it's personal choice and safety. Yes, Julia, it is appealing, isn't it? I totally get it. And what I normally say to people is that we can't compete on price, and we do get people who ask about stuff and ask about price and say, flipping out, you can have it done for half the price over here or over there. And I understand that, and I would love to be able to compete on price, but we can't compete on price. And what we can do, and what I truly believe on a world stage, that we can compete on the value that we give, the service, aftercare. I believe that we can compete on that on a world stage. I think we can compete on with anyone in the world in that regard. And you can't have a service where you're competing with other services in terms of value, aftercare, experience, service, and competing on price. You can't do both. You can't be price competitive and service, value, aftercare, give the best experience to everybody possible. It's just not possible. So you have to, something has to give. If you're going to be competitive on price, something has to give. If you're going to be competitive on service, something has to give. So for us, we're competitive on service, and the thing that has to give is the price thing. So we will attract people who are attracted to a comprehensive service and will pay the price for that. Other people will be attracted to a much more competitive price, but perhaps, I don't know, you have to talk about those places, but perhaps the service will be less competitive, but they might choose that. So that's where we are on that one. But I totally understand that a competitive price is appealing. And I do understand that. You don't look like you need one. I don't look like I need one. What? Facelift? No? No, thank you. Thank you for that, Nikki. If you go abroad, there's no aftercare whatsoever. Okay, unless you stay in that country for a few months. Right. Okay, yeah. So says Olivia. So there you go. Where are we up to? Would hernia be addressed? What do you offer aftercare? Why we don't do discounts? Here we go. This one now. Treatment of keloid scars. Is there treatment for keloid scars so I can tattoo over them? Well, is there treatment for keloid scars? Yes. So there are several treatments for keloid scars. Keloid scars are lumpy, raised, often red or darker colored skin, abnormal scarring, and they're difficult to treat, and they are prone to certain skin types, certainly for darker colored skin, Afro-Caribbean skin. Certain areas it's prone, earlobes, shoulders, sternum, are areas that are prone to keloid scarring. They're difficult to treat. And but there are ways you can treat it. You can, on a simplest level, massage. You can use silicone in the form of either sheets or gel. You can perform steroid injections. Those are the mainstay of treatment. For the more aggressive or problematic ones, you can cut them out, but then you worry you're going to get an even bigger one come back. And you can even use radiotherapy and other sorts of modalities, which are keloid scars. So there are things you can do for keloid scars. So you can treat keloid scars, but the question, can you treat keloid scars so you get them tattooed over? Blimey, I wouldn't, personally, I wouldn't. And the reason I wouldn't is because even when you treat it, you aim to make it flat. And but there's often a bit of a bump. And it's the bump that, I'll say I wouldn't. I mean, it's the bump that's the problem. So if you tattoo over a non-flat surface with a bump, unless you're trying to incorporate it into the tattoo, I don't know, it might not be the result you're after. So I think the other thing is keloid scar can come from a very minimal trauma. So if you're prone to keloid, you can get a spot or a chickenpox, scar or something like that, or the BCG injection or some minimal, or ear piercing, minimal trauma to get the keloid scar. So I would just be worried about having a tattoo personally. I'm worried that could that trauma cause keloid. So I would be worried about doing. So can keloid scars be treated? Yes, so that you can tattoo over them. Not sure I'd be encouraging you to tattoo over it, because I would be avoiding having any needles stuck in my skin if I am prone to keloid scars. Now, if it's a hypertrophic scar, that's a different situation. That's a scar that's had delayed healing, got infected, had a problem, and has ended up with a red, lumpy, raised scar, then that might be possible to be revised, because that might not be your body forming the scar, the ugly scar. It might be the fact that you had an infection or a delayed healing. But if you had normal healing and you've got a proper keloid scar is traditionally bigger than the original scar. So that's one of the hallmarks of a keloid scar. So you can end up with an ear piercing, which is a tiny little scar, because it's just a hole, turning into this massive, great big scar, which is much bigger than the original scar. I said scar a lot there, didn't I? I hope that makes sense. But anyway, yes, keloid scars can be treated, but I wouldn't necessarily be going on to the old tattoo afterwards on a personal basis. I wouldn't, but Donna, hello, quadruple question, exclamation mark. Got my 360 in 108 days, if it's still on. 108 days, fingers crossed, Donna, fingers crossed. We will be out of lockdown. Crikey, I hope to God we're out of lockdown in 108 days, Donna. Any recommendation for post 360 garments long term, in your opinion? Yeah, I mean, again, go with your surgeon. Are you a surgeon? But if I am, then go with what I say. But if not, go with whatever your surgeon says. And broadly speaking, there are two types of garment. One is like a Velcro thing that goes around, which can be a lot easier to put on and can be quite helpful, certainly in the early stages. It's quite adjustable. It's just literally a band that goes around your abdomen. And the other is a sort of proper garment, which has got a gusset and has got hooks and eyes and is a bit more fitted. It can be a little bit uncomfortable, especially in the early stages, because you're cramped up. and especially if you have a catheter or drains in, because the gusset doesn't do up because of the drains and all sorts, and then that can make it roll up and down. So there are some issues with it, but it is good when the drains and all that are out and the gussets on. It is a bit more supportive. Do you know what? Some people prefer one, some people prefer the other, both in terms of the patients and both in terms of the surgeons. I think there's good and bad about both of them, and sometimes we use a combination. But yeah, that's where I am with garments there, Donna. And the main, well, not the main thing, but one thing is you want to make sure it's fitting nicely, doesn't dig in, doesn't cause you ulceration, doesn't cause you red marks, and doesn't cause you problems, because they sometimes can. So you don't want the garment to cause problems. You know, you want it to be good, not bad. Jackie, I wish you did perform facelifts. Thanks for info. The wedding is the end of Feb. That's good. Yeah, no, I don't dabble in the old facelift arena, Jackie. I am breast and body is my ting. Kuram does facelifts, who works with JJ. Correct, Olivia. Thank you. Kuram does. Thanks, Olivia. Olivia is my PR manager. Thank you for that. No, she's not. Just said that, but yeah, I should have said that, shouldn't I, Olivia? Yeah, Kuram works in the clinic, and he does. Kuram Khan, he does facelifts. Yeah, but it's I don't. Karen's first time. Yeah, we should have like a star or ring a bell. I haven't got a bell. First time. First time. It's all right, Karen. Welcome. Thank you for coming. Do you know if fractional laser work burning the scar of skin is successful in inducing the appearance of scars? T-gank you too, Karen. Well, in my opinion, now, disclaimer, Karen, I don't do laser, but in my opinion, laser is good for red things. So laser is good if the scar is persistently red, and it can help to target the red pigment and to make it less red. Now, the problem is scars are often / usually red to start off with, and then they settle. They can take 6 to 12 months to settle, sometimes even longer, 18 months or more. So they can take time to settle. So my advice is normally moisturize and massage to help the redness fade, help the firmness to settle, and let them settle. And usually they do settle pretty well on their own. But if you do have persistent redness, then you might want to think about laser to target that redness, but it's not needed as often as I think people think. They often think, oh, if my scar's bad, I'll get some laser. But having said that, I don't do laser. So maybe if you spoke to a laser person, they'd be thinking that there'd be more applications for it. But that's my view of laser and scars. Being here for that. I hope that's answered your question okay. So Donna, thank you. Was thinking about the fitted one. Had a Macom after my BA, which was amazing. Still pretty good 3 years post 550cc HP unders. Get it in there, Donna. Get it in there. Okay, Donna's a 550 HP unders. Right? Adamant to get the best results. I can with the 360. Okay, Adamant to get the best results I can with the 360. I see a lot of Americans use amp boards in theirs to help. Would you recommend? What's an amp board? Oh my god, what's that? Oh my god, an amp board? Is that like a? What's that? Like a? Right. Well, Donna, people are different in terms of their view on garments, and some people are very prescriptive about garments, and like, for goodness sake, you got to do this week 1 to 2, and then you got to use the type 2 garment at 3 to 6, and then you've got to phase out and use this and that, and they can be very prescriptive. And I think some people will respond to that and think, yeah, I know what I'm doing, and I'm, you know, he's saying that these are the best ones and all sorts. But whenever you find that everyone's got different views, and some people are less prescriptive and some people use different ones, you realize there's no right or wrong answer. So the guy that's being very prescriptive about it, in his view, he's giving you the best advice, but it's not necessarily the right advice. It's just his advice and his opinion and how he manages his practice. So I think you'll find with garments, there is quite a spectrum. And I have had situations where the garments have dug in, the garments have caused problems. So I don't want patients to think, oh my goodness me, if I take my garment off, it's the end of the world. I better keep it on. And then they come back with an ulcer, they come back with a red mark or a wound, or you take the garment off and they're like, oh, thank God for that, I can breathe, because you've got to be able to take deep breaths. You don't want to get a chest infection, you know, you don't want to, you've got to be able to expand up your lungs, cough. The garment is there for support. The garment is there to help you and to support you and to give you comfort, really. So it shouldn't be it's not compression in my practice. Some people might say, oh, compression and swelling and all that. It's not compression, it's support. So yeah, so I don't think necessarily the garment will be the difference. You know, good will help you get through your post-op recovery if it is supportive and helpful and comfortable. But I don't necessarily think it will be like, you know, the answer to all your problems, or the cause of all your problems if you don't use the right one or something, you know. So I wouldn't be too prescriptive about it personally, but that's just me and my practice. You better go with whatever your surgeon says, you know. Surgeon's adamant, is it? Yeah, he used to be big in the 80s, didn't he? So yeah. So good guy though, good guy. So could do with a new job. Oh, Peter, yeah, good. More questions from Donna. Bring it on, Donna. Bring it on. Come on. I should have started earlier, shouldn't I? Do you recommend silicone strips for scarring? And what about a rollerball for massaging product into or lymphatic drainage? Well, Donna, funny you should say that. Because we have the dual action scar gel now available from the Stanham Plastic Surgery website and distributed from my home, because I've got them all over there. We also offer the smaller scar. Where's the camera? Oh God, scar gel there. So the 6G, or the big boy, 15G, and this one. So the big boy has got like a rollerball thing on it. See, it's got a rollerball. Check that out. That is product. This is what we want. That's got a rollerball on it, so that when you apply the silicone, the rollerball massages. What's the question? Do you recommend silicone strips for scarring? So these are gel. These are both gel. So silicone comes in gel or strips. To be honest, TBH, I would say, now they promote silicone. They probably say on it just for scar. Yeah, you know, treat scars. They promote it for scars. They say that it's for any scar, help scars, because I think they want to sell it to people, you know, because that's a big market, isn't it? Scars. To be honest, I would say to you, it's really for problem scars. For most normal scars, I think any massage or moisturizer, any sort of moisturizing cream. We also have. Oh, it doesn't know. I'm not going to go on. We got QV cream. Anyway, just whatever moisturizing cream you got. To be honest with you, to be perfectly honest, for me, it's more the moisturizing and the massage that's doing it, rather than the stuff you're using. So if you've got some hand cream that you normally use, or some moisturizer, we do sell some moisturizer. But anyway, if you've got some moisturizer you like, then I'd use that, to be honest with you. And that's the main thing for scars. If it's a problem scars, by problem I mean red and raised. Now that's a hypertrophic / keloid scar. So if it's getting a bit red and raised, a bit hypertrophic, that's when the silicone strips come in. So silicone comes in. So silicone really is beneficial for problematic scars. And silicone comes in the form of strips or gel. The gel is good for areas like the face, for instance, ears, you know, where it's a strip would fall off. You wouldn't want a strip on your head, you know, because the strips are good for maybe the breast, tummy, because your underwear can hold them in. I don't particularly recommend silicone strips for scarring, but if you have got problematic scarring, if it's red, raised, itchy, they can also help with the itch, then it is good. I don't think you were talking about the rollerball in this one about massaging product in, but massaging product in is good. And I think the fact that this has got inbuilt rollerballs, this is why we got it at the clinic, really, because I thought that was really good, that rollerball applicator, because it gives massage as well as the silicone. But yeah, massage is good. So if you know, a rollerball type of device to give a bit of pressure. Obviously, you've got to wait till the wound's properly healed. You don't want to be uncomfortable. Then that's good. Lymphatic drainage also is good, and lymphatic drainage not so much for scarring, but certainly for healing is good. Manual lymphatic drainage, excuse me, is a good thing to do. Yes, I do think that is good, Donna. Karen, thank you. Thank you. Your first timer, Karen. Nice to have you on board. Donna, like a firm board inside a garment. Not seeing many over here. Lol. I just worry about it giving pressure problems, Donna. I think I'll just be, and I don't think it's necessary. I don't think you really want to really push on that. You know, for me, it's not compression, it's support. That's where I am. Lisa's in the house. If I was considering multiple surgeries, that's it. That's the comment. If you were, Lisa, yeah, why not? That's what I would say. If you were, why not? That's my response to that. Jacqueline, with breast implant replacement, what is the effect on scarring? Do you utilize original scarring or are new incisions created? A, utilize incision. Well, actually, no. Oh, God, I can qualify that one, Jacqueline. Well, it depends whether this original scarring is. So personally, there's 3 different scars you can do, put breast implants in. Inframammary in the fold here, infraareola below the areola, and transaxillary. In this country, most of us use inframammary, the one in the fold down there. So if it's inframammary, I would, yeah, definitely use the same scar. So I would excise that scar. So I'll give you a fresh scar in the same area. That scar goes and give you a fresh scar in the same area. If it's transaxillary, and if it's me, I mean, if the surgeon's happy doing transaxillary, then yeah, definitely use the same scar. But if you've had it a way that the surgeon would rather do it a different way, so if you had, for instance, transaxillary, I would probably say to you, you know what, I'd probably just make a fresh infraareolar scar, inframammary scar, just because I feel that you got better access to the pocket with inframammary scar in my hands. It's all about experience, you know, not say the guy that does transaxillary is, you know, wrong or I'm wrong. It's just I'm more comfortable doing mammary because I feel I have better access to the breast and can get the pocket placement better, whereas I understand transaxillary is a more hidden scar, so I understand the benefits of it, but I don't do it. But yeah, so if it was a scar, an incision that could be used, yeah, definitely just use the same one, Jacqueline. Don't give you a new one, defo. Lisa is had to think about this now. Sorry, multiple surgeries, arm lift, breast lift, FDL. Which would you have first, as would the breast lift be after FDL tummy tuck? Do you know what, Lisa? I would say to you, I'd put it straight back on you, Lisa, and I'd say to you, what's the biggest problem for you? Because what happens if you have a problem afterwards, if the anesthetic's not very nice, you think, flipping it, I'm not doing that again. I would say to you, do the thing that bothers you most first, just in case you don't go and have the other thing done. That's where I am. Would the breast be after the FDL? No. If your breasts are, you hate them with a passion, and the tummy's, oh yeah, whatever, then do the breast. Do the breast, girl. Whatever. If the tummy's a nightmare, do the tummy. Do the one that bothers you most. My answer on that one, Lisa. That's where I am on that one. How much? Question mark. Is that a rhetorical question, Olivia? How much? Good question. How much is enough? No one knows. If only we knew. I ask as I'm a massage therapist, so hoping to help lymph drainage at home as much as I can. And ooh, look at that gel. Amazing. How often do you use that for? Woohoo! Yeah. Available online. Dispatched from Staiano Towers right here. So you massage, yeah, I think massage is good. I think it's good. I think manual lymphatic drainage is good at home. And what was it? Look at that. Sorry, what was the question? At home as much as I can. Yeah. How often would you use that for? What, the gel? It's only for problem scars, to be honest, Donna. So not particularly often. If I'm honest with you, Donna, if I'm honest, I mean, it's just you and me here, but it's only needed for red lumpy scars, keloid hypertrophic scars. As I say, I think they want to sell it to anyone with the scar, and but the evidence, in terms of medical evidence, the evidence is strong for lumpy red scars. The evidence isn't great. And what they do is they show you photos of a scar. They say 6 months after using this and the scar's gone. And you're like, well, hold on a minute. 6 months after massaging with normal stuff, or even 6 months with doing nothing, a lot of scars disappear. So for me, I don't think the evidence is strong for normal scars personally. There's no problem with it, but the evidence isn't strong for using it in all scars. Good, thank you, Donna. Would you personally do an arm lift and a thigh lift, maybe mini thigh lift in one op? Do not do, or not really, as it is all limbs. Yeah, B on that one, Donna. I don't think it would be a great one for you, Donna, or for the patient. I don't think it'd be a great one for the patient because having all limbs uncomfortable. It's not a great one for surgery because you've got to prepping and draping you is difficult because you've got to prep. Do you prep and drape the arms and the legs separately, or do you do them all in one? In which case your whole body will be exposed, in which case you'll go cold during surgery if we can't really cover your thorax. So prepping would be problem, draping would be problem. It'd just be awkward, and mainly the post-op wouldn't be very much fun for you, Donna. So I would tend to try and do upper, so you can combine procedures, but like arm lift and breast thing, thigh lift and tummy thing is sort of more of a standard combination of doing things rather than doing an arm and a leg. I don't think it's a very good way to recover. I don't think it'd be much fun personally, Donna. Olivia, scar gel. Oh, how much is a scar gel? Oh God, got no idea, Olivia. It's on the website. Sorry. I don't know, 30 quid or something. I made that up. I don't know. Sorry, it's on the website. Anyway, it's on the website. I won't do it now. Sorry, Olivia. I'll let you down. I don't know what it is, but you can get it from other retailers like Amazon and, well, I shouldn't mention the name, Boots, chemist, pharmacy. It is available over the counter. Lisa, my arms are horrible and my breasts are awful, but I don't want the FDL to pull down the boobs. Not sure if tummy tuck affects the boobs. Not really, Lisa, not really. Your inframemory fold is pretty set, and I know what you're saying, but your breasts, it's your breasts that are droopy, not the fold. So it's the actual breast itself. So you're having a tummy tuck is not going to make your breast droop more. No, it's not. It's not. So it won't affect the boobs. Good one. Dawn's off, guys. 8 o'clock, Dawn's bedtime. Okay, Dawn. Night, everyone. Night for Dawn. Thanks for coming, Dawn, and see you next week. We'll stay up if that's okay, but yeah. I don't know when that. I hope you haven't gone already. Anyway, Dawn, thanks for your questions, Dawn. You've done well tonight. You deserve a rest. Donna, I'm having a lower body lift 3 years after boobs. Apparently they won't pull them down. I've asked this wonderful guy before too. Go for it, girl. There you go. Is this wonderful guy me or someone else? Anyway, there you go. So Donna's backing me up on that. Won't pull them down. Olivia's having thighs and boobs in one go. I haven't let her down, which is good. Thank you. Thank you for the question, Lisa. Thank you for the question. So I'm going to go over here to do my next question, which is Keloid done that one. Good candidate for, what's that? Oh yeah, this is the good candidate for facelift. Who is a good candidate for a facelift? What is the best age to have a facelift? What is the recovery time for a facelift? So we touched on a bit of facelift issues earlier. So what is the first question? Who is a good candidate for a facelift? A good candidate for a facelift is someone who feels that they are who is well, I don't do facelifts, all right, disclaimer, but it's someone who feels that their tissues are going, it's a bit like the same for the breast and the tummy, going south. Everything's a bit totic. They feel, totic means sort of droopy. They feel that they find it hard to sort of in terms of wearing makeup and what have you. It's hard because the structure and the jowls and the jawline isn't well defined. Sometimes the neck is a problem with the excess skin in the neck. And the best age for a facelift is well, first of all, it depends on if this bothers you or not. And like people say, would you see this person have cosmetic surgery or not? If it doesn't bother you, then there's no age. But it would probably be sort of 50s, 60s would be the sort of age you'd be thinking of someone in terms of a facelift. Now, having said that, let me roll back a bit. There's different types of facelift, you see, and there's a spectrum in terms of what, you go right from sort of non-surgical stuff, which shouldn't really be called a facelift, but sometimes people call it non-surgical facelifts and stuff, up to a full facelift. So, and there's stuff in between. So there's things like a mini facelift where they just make a scar here rather than a full facelift. There's this one stitch facelift where they just put things under the skin and they hitch things up, much less invasive, local anesthetic and sedation sort of things, where they just do a little hitch. I say the because it's not they, because it's not me. So there are different types of facelift. So what I was talking about is like a full facelift, which is quite an invasive procedure. That's the one with the sort of 6-week downtime, bruised, battered stitches, scars, and then it progresses down to less scars, progresses down to just putting these stitches in these anchors where they anchor the tissues up without actually cutting skin out. Now, in order to cut skin out, you create scars. So there are types of facelift, if there isn't a huge amount of excess skin, where you can just anchor the tissues up without actually cutting any skin out and therefore not leaving any significant scarring. So the problem is it's less of a lift because you're not cutting any stitch out. So it's always a balance. Less of a lift, less scarring, less downtime. More of a lift, more downtime, more scarring. So the older person might need more of an extensive surgery, whereas a younger person might be able to have a lesser surgery, which will therefore give a less of a result, which will therefore, all of the results, doesn't matter which one you have, will then be acted on by gravity, and will, the face or the body will droop or sag again because we're all acted on by gravity. But obviously, the bigger the result, the longer it takes to recur than the smaller results. So you got to do the balance, because you might say, I don't want downtime, I don't want scars. Okay, we'll have the smaller one, but you might need something done again sooner than if you'd had the bigger one. So it might be a false economy, might not. So the age would vary on how extensive a lift you have. Is that all right? What is the recovery time for a facelift? So as I say, that was earlier. So that was a 6-week thing I'm talking about with the full facelift, but they talk about these sort of little lifts and these little one-stitch things, where you're back a few days, a week. I don't know. I don't really do them, to be honest. I don't really know, but I think they're a lot quicker for the less invasive ones. I haven't answered that very well, have I? Anyway, is that okay? Or I missed anything? Thank you for that answer. I said that. Thank you. Yeah, I did. I said thank you for the question. Asked you. What's that referring to? Oh, I'm the wonderful guy. Lisa, do you have a limit on BMI for arm lift, boob lift? Yes and no, Lisa. Yes, because it's 30. No, because it's not written in stone. So if someone asks me, I'd say 30. I'd say 30 is better to be a BMI less than 30, basically. Now, sometimes people will say not doing it unless it's whatever, 30 or whatever. I don't have a specific thing where I'll say, look, I won't do it. I try and have a conciliatory sort of partnership with patients and say, look, there are studies which say you're going to have a better result, less risk of complications if your BMI is less than 30 than if it's above 30. Now, I do surgery on, or at least I have done surgery on people who BMI above 30, but these are usually people who've lost a significant amount of weight. And the important thing is they're happy with their weight. So the first question is, are you happy with your weight? Because if your BMI is above 30 and you're happy with your weight, you don't really want to get it falsely below 30 just for surgery and then put it back on again. So if you're happy with your weight, that's one thing. Now, if you're not happy with your weight, and I understand it, you might say, look, I'm not happy with my weight, but once I get my tummy tuck and I get my arms done, they'll be able to exercise better because I've got this big apron here and my arms and all that. I understand that. But if you're not happy with your weight, you're much better to get your weight down first, because you don't want to have significant weight fluctuations after surgery. You really want to get your weight right first before surgery, because if you have significant weight fluctuations after surgery, it can have an unpredictable result on the effect on the result. So really, you want to have a stable BMI, ideally below 30, but doesn't have to be below 30. But if you can, particularly if you've lost a lot of weight, sometimes if people have had a BMI of 45 and it's gone down to 32, it's a bit harsh to sort of say got to get it down to 30, because but yeah, the lower you get it, the better. Less risk of complications, and you're going to get a better result if you can lower. So it's for you, really. Olivia may consider a one-stitch facelift. Okay, there you go, Olivia. I've sold the one-stitch facelift. Good. Where are we up to? Who is a candidate? This one here. Oh, here we go. Hi. This is a good one. Is that up? Oh, no. Where is it? Hi, it's just a question for tonight's live Q&A. So I'm looking for an uplift in implants. My breasts are asymmetrical, so I've been advised a lift and 2 different sized implants. Just wanted to ask a question to help any other ladies who may be in a similar situation, but too embarrassed to show. So this person is, I put this deliberately towards the end because I got a photo, and I'm worried that I might get, disciplined by Facebook. Now, thank you for putting things over the areas of the body that maybe are supposed to be shown. So, what time is it? 8:15. Is it acceptable? I'm going to show a photo now. So, if I guess I should disclaim it now. So, if you've got, not disclaim, but if you've got children watching, maybe ask them to leave the room or turn the computer away now. I've got a photo here. I don't know. I like showing photos because I think it helps to get an idea, but I don't want to upset anyone or be told off by Facebook again. God knows I've been told off enough. So I'm going to show the photo in 3, in 2, in 1. Photos coming up. So this is a photo here. Right, so I hope I don't want to get that way around. So this photo here, so a bit of a breast asymmetry, one breast bigger, I don't know, you see one breast bigger than the other, sitting a bit low. Nothing too drastic, but yeah, good question. So I better, yeah, I got away with it. I haven't got banned yet. So, so yes, thank you very much for letting me show the photo. So this is a good question. So, breast implants under or over the muscle. So really interesting, and this is a question that will be answered differently by different surgeons. Ask 10 surgeons, you're going to get, well, probably not 10 answers because there's only 2 answers, but 5 of each maybe. Anyway, and it depends on how much tissue you've got in the upper part of your breast. If you've got enough tissue, enough soft tissue cover, then I would put it on top of the muscle. And looking at the photo, that's where I'd be inclined to go. I'd want to examine you in clinic, so just to disclaim that, but that's where I'd be inclined to go on top of the muscle. And the reason I go on top of the muscle, because I worry that one of the risks of putting the implants under the muscle is the muscle holds the implant high. And if the muscle holds the implant high and your breast's sitting low, it doesn't look good. So I would therefore put it on top of the muscle. Now, if you're very slim and you do have, particularly if your rib cage is showing, you worry that you're going to see the edges of the implant, you're going to feel the edges of the implant, you might get visible rippling. So that would be the worry, and that would be the reason to put it underneath the muscle. But some people say, oh, but under the muscle is better, isn't it? Or over the muscle is better. I'm like, no, one isn't better. If one was better, we would just do it that way. The problem with putting it underneath the muscle, because you might say, I don't want to have rippling. I want to be able to see the edges. Oh, well, have it under the muscle. The problem about under the muscle, as I say, sometimes the implants are held high, sometimes they're held wide. If you see a particularly wide cleavage, that means they've had them under the muscle. They haven't released the muscle enough. And sometimes you get animation deformity. So when you do the gym and things, the breasts move because the implant is underneath the muscle. And when you tense the pec major muscle, the breast moves. So there are good and bad about putting under the muscle and over the muscle, but on that one, I would probably put them on top of the muscle, although I would have examine you in the clinic to have a look at your subcutaneous covering. in the upper part of the breast to see if there's enough cover to sort of hide the implants. Now, the other thing it was saying, what was the other thing it was saying? Oh yeah, the asymmetry. Yeah, so there's two ways you can address an asymmetry. If you're just having implants, then obviously it will be what's called a differential augmentation, where you put a bigger implant in the smaller breast. But if you're having a lift with implants, you could still do that, lift both and do a differential augmentation, or you could do a small reduction of the bigger breast and then put the same implants in. No right or wrong. I've done it both ways. Pros and cons of both. The pro of doing the lift and different size implants is that you're not removing any breast tissue. Obviously, you want to maximize the amount of breast tissue in order to get maximal cover over the implant. The benefit of taking a bit of tissue out of the bigger breast and putting same size implants in is that then as you age, as your body weight and fat and what have you goes up or down, then they'll do that equally, because there'll be the same volume of breast to implant in both sides. 6 and 2 3s. But yeah, that's fine doing it whichever way. And then what I say to people, this isn't my patient, so your surgeon might have said this to you, but what I say to everybody is there's probably still going to be some asymmetries, whether you do a differential augmentation or whether you do a reduction of the bigger breast. There'll probably be some asymmetries, but we're trying to bring it back into proportion and make it look more balanced is the goal. So that's a good one, and thank you for the photo. What happens if they get infections, problems? Would they need to go to the NHS, or would you treat them? Right, that's good. Thank you for the scroll. Yeah, see, I get this. I do get this. I think this is talking about people who've gone abroad or gone elsewhere for surgery, and I do get people sometimes who've gone abroad for surgery who want to have, I don't know, stitches taken out or aftercare, basically. And no, I would not treat them. I would not treat them. And the reason for that is the way it's set up in this country anyway, is that we get paid for the surgery. So the surgery is a certain price, and the aftercare is included. It's part of that price. And so there isn't a separate price for aftercare. The price is for the whole package, the whole thing. Once you've got a patient, they're your patient and you look after them. And that is how we practice. And that is how we've been brought up. And that's how the medical system is in the UK. You are responsible for your patients. And therefore, once there is someone who's a patient of yours, you are responsible for them. And the same is, so if you have it done abroad, really it is that surgeon's responsibility to look after you. So if you have it done abroad and say, look, oh, can me look after you? I'm like, no, not really. Number one, because I don't feel comfortable looking after another surgeon's work. It's his or her responsibility. And number two, that's not how you can't sort of, I might charge, £7,000, £10,000, £15,000. I don't know what, thousands of pounds for something. They might charge £1,000. What, I haven't really got a price for just the after. I'm not going to just say, okay, well, pay me £10,000 to do the aftercare. We don't have a price for aftercare packages. The aftercare packages include. That's why. Well, that may be. You have to look into what they're offering, but that may be one of the reasons that it's £10,000 here, and I don't know what the difference of prices is, but a different price in one place to another place. Maybe that there's different levels of aftercare, and unfortunately you can't just sort of bolt on an aftercare package afterwards. So yeah, you really you shouldn't really either be going to the NHS. If you have private treatment, I mean, the NHS will help you if you are ill. I mean, there's no question. If you're ill, if you're septic, if you're if you're ill, the NHS is brilliant. It will help us all. It's there for us all if we're ill. But as I said before, if you have a treatment by a doctor, and there is a complication or an issue, it really, the first port of call should really be that doctor. And most would probably want to be the first port of call. We want to look after our patients. I don't really want my patients going to see another doctor with their problems. I want them to see me. I want to have an opportunity to fix it and to treat it from and sort of moral and ethical responsibility. But also, I'm best placed. I did the surgery. I know exactly what I've done. One's bigger than the other. Well, that's because I struggled with one and it was a bit bigger, and it's not that it's swollen, or flipping heck, that's swollen. I know how big it was or small it was or whatever. I've done the surgery, so I'm in the best place. So really, if you have infections or problems, you should go and see your doctor who did the treatment. And I totally understand it, that if it's in somewhere far away, it's difficult, which is why I always say to everybody, it's best not to go far away. And that's the same for people who live far away coming to see me. I say, look, you know what, you're better off, because if you have a problem, I'll say, look, come and have a look. I can do videos. I can do, we can help and liaise with GPs in terms of prescriptions and things like that. But it's not ideal, and it would be better to have it done closer to home. So in answer to the question, no, I wouldn't do an aftercare type thing. So if someone contacts me having had surgery elsewhere, I would say to them, look, you really need to go and contact your doctor, because they're really responsible for that. Sorry, what's happened? Has anything happened in the chat? Do you have an update for BMI? I may have one still done that. Oh, here we go, Lisa. I've lost nearly 8 stone. Well done you, Lisa. BMI was 50. Wow. It's now 31. What? 50 to 31, that's crazy. Still going down, but my arms are causing me problems. Yeah, well, if it's still going down, Lisa, keep it up. I say 30 as a cutoff. If it's still going down, go to wherever it's going to go. Go where you're happy and stable. Don't listen to me about 30. 30 is just a sort of ballpark. If you can keep on going, then do keep on going. Photos are always good. They are, aren't they? You are great. Thank you, Olivia. That's kind. Let's leave that up there for a bit. Natalie, thinking about being able to see the implants due to your size/weight. I'm a size 8 and you can see my ribs, so that's probably why the surgeon is saying to put my implants under the muscle. I always wondered why, so now I know the answer. Yes, exactly. So if you can see your ribs, that's sort of like a ballpark sort of assessment. If you can see your ribs, so I say to people, look, if I can see your ribs, if I can do like that, and I know I'm going to touch a rib because I can see it, then if you can't hide your ribs, how can I hide these implants? If you can see your ribs, you're going to be able to see the implants. And the other thing I say to people, if they're having on the muscle goes, the pec major goes from your arm down onto your breastbone. It goes across like that. That's how the pec major muscle sits. So this bit here is always not under the muscle, sort of thing, so it's not under the muscle. So you might have rippling and things laterally. If you're very slim, you might have implant rippling laterally, and it might be a question of like, that's because you're so slim, I can't hardly hide the implant. It's what it is. That's, just don't have surgery, take it or leave it. That's what it is. If you're very, very slim, you might get rippling, you might be able to see the implant, you might be able to feel the implant laterally, even if you have them under the muscle. And it's all about having this conversation before having the surgery, because then you accept it better afterwards, rather than us saying to you afterwards, oh yeah, you can always feel it laterally, yeah, because you haven't got any muscle there. And you're like, oh, thanks for telling me that now. Yeah. So what we got, how long are drains in for and what are they used for? So it depends on the op. Don't use drains on many ops these days. Tummy tucks, big breast reductions, capsulectomy of a breast implant, removing the capsule. So operations where there's a bit of ooze. So there's a bit of an ooze, a bit of a dead space, if you like, with a tummy tuck. There's a bit of a space there. So the drains are suction drains, continuous vacuum, and they help to suck down the tissue. So that's really what I use them for. if there's a sort of raw surface, like with a capsulectomy, where you're taking out the capsule of the implant, and for a tummy tuck, where you have to undermine up to the rib cage. So there's a raw surface, and the drains will suck that surface down to help it stick together, to reduce the risk of seroma, fluid collecting in that space. That's really what they're for. People often think they're for hematoma, which is blood collecting inside. Maybe, but the evidence is not strong to say that they're for hematoma, but it's really for just to help the pockets cut down, stick down. How long they're in for? Surgeon dependent. Personally, usually 2 nights, one or 2 nights. Breast reduction maybe 1 night, tummy tuck maybe 2 nights, maybe 3. 1 to 3 nights, let's say. Personally, I don't like sending people home with drains, so they come out before you go home. Some people do. Some people send people home for drains and come back 2 weeks later or a week later or something like that. I don't like sending people home with drains, so I pretty much never, I would say I never send anyone home with a drain. So the drains are in while you're in hospital, and then they come out, and then you go home. So you don't really go home with drains. But that's really what I use drains for. But everyone, people might have a different view on that. But that's mine. That's my view. How long after a tummy tuck before you can ride a bike? Well, you know what? Riding a bike is good exercise. It's not impact. There's no impact there. So it is actually good exercise. And in terms of a good exercise after surgery. So I would say you'd ride a bike quicker than if you're running and things like that, particularly if you're doing exercise bike at home, where you can just gently do it, because you don't want to go on a long bike ride and then think, oh my lord, my tummy's killing me and it's all swollen and I feel terrible, and you've got to get back again. So if you can start at home, maybe on the exercise bike, I would say gently 2 to 3 weeks. Gently, that is, mind. I'm not talking about going on the Tour de France or getting on your racing bike and going up a hill, not too much exertion, but gently on the level, pootling down the canal towpath. Yeah, 2 to 3 weeks, maybe. If it feels okay, listen to your body, particularly the exercise bike. I think 2 weeks exercise bike, maybe 3 weeks for a real bike, and just take it easy. But again, tummy tuck's a big op. You might have problems. You might have a bit of wound healing, this and that. So it might be longer, but that's sort of, average. Last question. I'll tell you something, guys. Last week, I had, about 4 o'clock, I had one question. I think I did have 1 or 2 questions in between, but I had loads on the chat. But this week I've had a good, it's restored my faith in the lockdown, honestly. So good haul of questions this week. I had surgery abroad, mummy makeover, and not able to be checked over for obvious reasons. I'm getting a lot of tingling pain, shooting pains, to the point it is waking me at night when I turn. Would you suspect this is normal nerve pain for 360 lipo tummy tuck in my side flanks? Yeah, a lot of tingling pain, shooting pains. Tingling, yes. Tingling is healing. So tingling is fine. There's a bit of a border here between tingling and shooting pains that are waking me up at night. So I'm thinking it's probably okay. Now, you're not able to get checked over, but you're able to phone and Skype and all that sort of stuff. So again, I would try and contact your surgeons, because it is probably something your surgeon is best placed to talk to you about, particularly for a 360-degree tummy tuck, which is a big op. So really, you need to speak to your surgeon about that, whether or not they're abroad or whatever. They should still be contactable, you would hope. But in terms of tingling pain, or at least tingling, is often a sign of everything knitting together, not necessarily a bad thing. Pain, slightly more worrying, especially pain that was waking up at night. You think, is there something there? But if it doesn't look particularly swollen, if the skin doesn't look red, I'd probably be more reassured. And I would suspect if the skin was red and it was swollen, you would have said. So if it looks okay and it's just tingling and discomfort when you're turning, it is a big op. When did you have it? Doesn't say. No, but it is a big op, and it does take a while for these sorts of weird feelings, and you can get sharp pains and what have you, to settle. But having said all that, always best to get your surgeon to at least maybe talk to you or get an opinion on it. But tingling and stabbing pains and things is not unusual after surgery. And we'd really be looking for, the sort of things I'd be looking for is a bit of redness, swelling, wound not healed up properly, these are the things that make me think, hold on a minute, do we need to do something? But if the wound's healed nicely, skin's not too red, it's not got any swelling, not really tender to the touch, if it's just sort of tingling and a bit of sharp pain when you're moving at night, doesn't sound too worrying to me. But it's my view. Disclaimer. Olivia, I had a drain after a gastric sleeve for 4 days, but not much came out. Was a pain in the neck carrying it about. Yeah. So no one likes drains, Olivia. No one likes drains. We try to use them less and less, but we still use them for some ops. But yeah, they are a bit of a pain. And sometimes not much comes out. You think, what was the point of that? Sometimes a lot comes out, but it does help to encourage the tissues to sort of stick together. Certainly in terms of the tummy tucks and things like that. Not so much for the gastric sleeve, but. Well, I said this. That was the last question. I think that was the last question. I'm out of questions. Was it me or was that a belter? Tummy tuck, tingling pains. That was the last question. That was a belter. So hope that was helpful. How many days in quarantine are we? Where's my widget? How many days? I don't know how many days. It's not 23, is it? Huh? 56? It's not that much, is it? 36 days in quarantine. I don't know. How many is it? What's that? What's your temperature? Oh, I don't know. 37.1. That's it. Normal temperature. Good. Thank you all. Thank you all for coming. Thank you for your input, your questions. If you have any questions, feel free to get yourself on the Facebook, get yourself on the message. This is also going out. I want to big up the podcast subscribers. I want to big you guys up. You're unsung heroes because you don't comment on the Facebook because you're out there in the world listening to your podcast. I don't know about you. I'm listening to less podcasts now because I'm not in the car so much. But if you are a podcast listener of the Styano, what's it called? The Styano Clinic podcast, is it? Or Styano Plastic Surgery? Anyway, the podcast. This goes on the podcast. So big yourself up and feel free to get onto Facebook and ask me a question. Natalie, positive news. Some NHS services are resuming, hoping plastic surgery follows next. Yes, they are, aren't they, Natalie? And that is good. And I think plastic surgery will follow behind. And we're very hopeful. And as I say, we are preparing for the comeback. We are definitely preparing for that. It was a belter. Thanks, JJ. Could be 4 weeks in lockdown. Yeah. So, yeah, we are definitely preparing for the comeback. And I am going to go and get the kettle on for a Horlicks. And I suggest you do the same. I will see you same time, same place next Tuesday night. Be there or do something else, but preferably be there. Checking myself out of here. Thank you all. Thank you for the wonderful comments, the questions. Loving it. Keep it coming. Keep it coming. But right now, I'm stopping the stream. The stream is being stopped.